So let's begin. Now, what is the meniscus? It's a crescent-shaped fibrocartilaginous structure present between the femur and the tibia. The medial meniscus, as you know, is C-shaped, covering more than half of the tibial articular surface. Lateral meniscus is slightly shorter, covers more than 3/4 of the tibial articular surface. The vascular supply is by the geniculate arteries via the perimeniscal plexus. Now, there are three distinct zones. There's a peripheral red or a vascular zone. There's an intermediate red-white zone, also called as zone of transition, and a white-white or an avascular zone, which is the innermost zone. Now, in brief, the main functions of the meniscus: this load transmission, shock absorption, stability, joint lubrication, and proprioception. Now, why is repair important? Why arthroscopy surgeons after the repair? Well, a study by Bryceland showed that the meniscus is responsible for more than 50% of the load transmission across the knee. In full knee flexion, the lateral meniscus transmits 100% of the load along the lateral compartment, whereas the medial meniscus transmits up to 50% of the load on the medial side. In complete meniscectomy, the contact area is reduced by more than 50%, causing a dramatic increase in load per unit area. A partial meniscectomy, even as little as 15% to 34%, can increase the contact pressures to up to 350%. Now, how do we repair the meniscus? The ideal case would be a tear in the peripheral red zone, a longitudinal tear, and up to 3 centimeters long. The principles, obviously, they have to be, and you need to visualize the meniscus, so you require to do a pie crusting of the MCLs a few times. We also need to create a favorable biological environment, which can be done by debridement of the menisci using a fibrin clot or a PRP. A limited notchplasty or the microfracture of the lateral femoral condyle can also help to augment the healing. Now, what are the techniques of repair? Well, there are mainly three: the inside-out repair, the outside-in, and an all-inside. We'll just show a small video where we've demonstrated all the three techniques. So this is a medial meniscus. Medial meniscus is a bucket handle tear of the medial meniscus, and you can see the medial meniscus is in the notch. Now, the first step would be to reduce this menisci back to its original location. So this is the reduction of the meniscus. After the reduction of the meniscus, we proceed with the meniscal debridement to just generate some bleeding, which will help in healing. Here you see a cannula coming in. This is mainly a cannula for an inside-out repair. 2 needles are passed through this cannula in a parallel fashion. These needles have a fiber wire attached to it. We make a safety incision, and the needles are brought out to the posterior medial side. Here you can see another suture being passed through, and the circle that marks the fiber wire. So the needles, when brought outside, are cut, and the meniscus is repaired in a horizontal mattress fashion. Now, this is an outside-in repair using an 18-gauge spinal needle. We load a number 1 PDS through it. The PDS is then brought out through the anteromedial portal. And a fiber wire is shuttled. The 18-gauge needle is again passed, and the remaining limb of the fiber wire is shuttled again. In this way, we can achieve a horizontal mattress repair. So this is the situation post-repair. We can see a well-reduced and a stable meniscus now. It's well reduced to its original location. This lady also had a longitudinal tear of the posterior horn of the lateral meniscus. Now, this is an all-inside device. Here you can see the suture going through the superior portion of the meniscus and again into the inferior leaflet. Once the sutures are passed, the fiber wire is cinched to approximate the torn ends. So, not all tears are amenable to repair. Sometimes you need to do a partial meniscectomy. What needs to be kept in mind is, even if you're doing a meniscectomy, we need to resect as minimum as tissue as possible. Some patients, especially the ones after a road traffic accident, end up with a severely damaged, degenerated meniscus. So in these cases, they may end up with a near total meniscectomy. They need to be sensitized about the need of a meniscal allograft transfer at a later date. A brief word on root tears. Now, root tears are similar to a total meniscectomized knee. A study by Laprade and group found out that if these tears are left untreated, can lead to insufficiency fractures, spontaneous osteonecrosis of the knee, and early onset arthritis. The Laprade group did a study on about 200 knees who were posted for a total knee replacement, and they found a posterior meniscal root tear in 78% of the patients who are under 60 years of age. So that tells you how important this root is. So whenever you find a root tear, it needs to be diagnosed correctly, and it has to be treated appropriately at an early date. So to conclude, even though we've made great strides in implant design and to achieve the clinical and functional outcomes after a total joint arthroplasty, there is still no implant which is as good as a native knee. Hence, a meniscal preservation and joint preservation should be given utmost importance. Thank you.